It's my pleasure to introduce Bob Kramer, the author of Depression Dynamics. Bob answers 88 questions about depression in his 3-cassette audio program. As a nationally recognized authority on depression, Bob has served as a spokesperson for the National Institute of Mental Health Depression Awareness, Recognition, and Treatment Program. As a lay expert, Bob's mission is to help others by dispelling the many myths and misconceptions about depression, its cause, and its cure. Bob's professional affiliations include being an active member of Mensa, the Cincinnati Professional Speakers Association, the Ohio Speakers Forum, and the National Speakers Association. Let's give a warm welcome today to Bob Kramer.
Thank you, Dr. Hunter. And good morning. I've got to tell you, I'm really excited and enthused about depression. Sounds kind of funny, doesn't it? But it's true. I'm excited because there's so much public ignorance that I can help to change. And I'm enthused because there's so much good news that I have to share. But I'm also concerned. I'm concerned because there's so much depression. I'm concerned because of public ignorance and public stigma. Only 1 out of 3 people who suffer from depression seek treatment. I'm concerned that the average person waits 7 years before seeking treatment. And depression's been called the common cold of mental health. In your lifetime, 1 out of 4 women and approximately 1 out of 8 men will suffer depression. At any one time, there's 1 out of 20 in any group suffering from depression. Now, why is it that 2/3 of people never get treatment? Because what really concerns me is the 2/3 who do not get treatment, ultimately, who have a serious depression, 1 in 7 will self-destruct. Among teenagers, suicide is the second leading cause of death after accidents. In a recent federal survey of 11,631 9th through 12th graders, they found out that 27%, over 1 in 4 teenagers in high school, seriously considered killing themselves in the last year. 1 in 12 actually tried. So I hope you can understand why I feel like I have a mission or a mandate to share what I know about depression. Because depression is truly psychiatry's greatest success story. It's probably the most treatable of mental health disorders. The problem is public knowledge is like 2 centuries behind the rapid advancements that we've seen in the last few decades. There's been tremendous advances in the psychologically based treatments of cognitive therapies, and even more amazing advances in the pharmaceutical approaches to treating depression. Now, I could talk about depression for a long time, and perhaps still leave some of you with unanswered questions. So I'd like to attempt to do this morning is do things kind of backwards. Start by entertaining questions that you have first about anything about depression you wish to ask. Its cause, its cure, its incidence. Like, how many of you realize that our country loses $27 billion a year economically because of depression? $10 billion alone from the 127 million days lost to work. Any questions about any type aspect of depression, I'll be glad to share my personal experience with you or what I've studied about it. Do we have any questions this morning?
Do you think that depression is psychological or physiological in nature?
Okay, that's a good question. That's a common question people wonder. Is depression psychologically or physiologically based in depression? I really believe that most depressions have mixed roots. My belief is that people probably inherit a biological vulnerability to it, but then normally some outside event, some outside adversity, some activating agent triggers it. I also think that a great disservice has been done by trying to separate depressions. They used to say, well, he's got this kind, he's got that kind. Personally, a great disservice was done to me when I went to my first physician. It was a psychologist, mental health center, for treatment because I was depressed. I said, am I in the right place, or should I be getting medications, drugs? Should I be doing this, doing that? She said, no, you're fine. I wasn't fine, but she said, you're in the right place. She said, drugs would be a waste for you because you do not have an endogenous type depression. She said, yours is not from within the body. Yours is reactive. I had just come out of winning a major lawsuit that cost me all my life savings, so I was depressed. She said, it's a reaction to that. But see, what I'd like to do is use this opportunity to really answer this question. I want to go into quite a bit of depth on this because this is a key question. And I think while answering your question, I can answer many other questions about the interaction, what I call it depression dynamics. So I developed my own model based on what I've read. I like to use analogies. So we're going to look at it as a little pony ride like you see at the carnival. And we've got 4 ponies. We got Mr. B, who's behavior. We got pony Mr. T, who is the thoughts. We got pony Mr. F, who's the feelings. And we got pony P up here, physiology. Now, what's interesting about this pony ride is these are the way the ponies are connected. It's not the kind where they're in a corral and they roam freely around. You've seen the kind with the crossbars at the carnivals. where the ponies are chained together. Now, my belief is it doesn't matter if a depression starts over here cognitively based on, say, take a job loss, for example. Let's go through a couple examples. A friend of ours was recently fired at age 45 from work. He became very depressed, and he said to his wife, he said, you know, honey, I'm really worth more dead than alive. And this is what he truly felt and believed, because he was not employed, he was not making any money, he felt like he could not find a job, who'd hire an old man at 45, et cetera, et cetera. So his depression really started here. But the thing is, it's a dynamic model. Once this pony starts to move or stops, the others are going to stop with it. And what happens, he first had this negative event, and he started having all these negative thoughts about himself, which then got this pony going over here saying he feels worthless, he felt useless, he felt hopeless, he felt despair. This just creates a lot of stress on the body. So immediately the physiology is affected. Because whenever you have stress, adrenaline is pumped into the blood. And the adrenaline is the culprit because it reduces the levels of neurotransmitters in the blood. Adrenaline is epinephrine. Epinephrine reduces norepinephrine. The serotonin levels drop, the dopamine levels drop. So there's immediately a physiological change in the neurochemistry, so the person now cannot physiologically think properly. His thoughts are distorted like static in a radio. This affects his behavior. Physiologically, he's not sleeping as well, he's not eating well, so he gets up later. Now he's starting to feel even worse about himself. He's thinking, well, gosh, I'm really lazy. I sleep till 9 o'clock. The thing's a vicious spiral. Now, depression can start over here. Postpartum depression is a good example of a truly physiologically based depression. Many women who've excited about having this baby, all of a sudden, after the birth, it's happened, they become suicidal and homicidal towards the child. It's because of the great hormonal upset. It's really screwed up the brain neurochemistry. So the depression starts here, but again, the whole dynamics begins. The physiology affects the behavior, the physiology affects the thoughts, it gets the feelings going, and the thing goes on and on. Another question I'll answer related to this, what's the best way to treat depression? Because a behavioral approach alone does work. If these ponies are moving, just getting this one going or stop will affect all the others. This is why many different therapies work. Cognitive therapies do work. Many times depressions are treated just by changing the person's distorted thoughts. You're not loose, you're not hopeless, you can find another job. But the best approach, I think, is to attract it eclectically, the ones you can affect. This guy kind of gets a free ride, but work through the cognitive work, the behavioral work, and many times the antidepressant medications make a tremendous difference quickly. Other questions someone might have?
Yes. How is it that you feel qualified to answer questions about depression? I guess what I'm really asking is, why would somebody want to listen to you rather than to a doctor?
Well, that's a good question. Let me answer your question with a question. Let's say you want to learn about sex. Okay, you want to know what sex is really like. What does sex feel like? What's the experience like? Would you rather learn from somebody who studied all about it or somebody who's done it? I've done depression. And I've also studied about it. So I feel like in many ways I'm more qualified to answer the questions than a physician. See, a physician who's caring can be very empathetic to the patient. But I, who've had the personal experience, can identify with the patient, and they can identify with me. And as a professional speaker, I know that people are only willing to listen to your message to the extent that they can identify with you. I think that gives me a big advantage to share my personal experiences. Many times when I do my seminars, my lectures, the feedback I get, what we appreciated most was your personal sharing. People know they're not alone. They know exactly, someone else knows exactly how they feel. Other questions? Anyone else? Yes, over there, way in the back.
I had a question about the antidepressant medication. What kind of side effects do you have and how safe is it?
You really give me two questions. Are antidepressant medications safe? Do they have side effects? Let's look at safety first. I'm going to really address primarily the tricyclics because they're the ones commonly prescribed. The monoamine oxidase inhibitors aren't used near as much because there's food interactions, and they have a little bit different side effects. But the commonly prescribed antidepressants, let's talk about safety. First of all, you must realize that there's no medication, no medicine, that's 100% safe. People have been known to die from normal doses of aspirin. They've bled to death. So you always have to look at the risk-reward ratio. Now, what I know about depression, the statistics, the suicide statistics, I feel that the medications, it's 100,000 times safer to take one than to not get treatment. And people have a lot of hang-ups about medications. It's just like there's public ignorance about the depression, the way it works. There's public misconceptions about the way the medications work. People say, well, I don't want to take them. In fact, they've done surveys. This was a Roper survey done in '86. 65% of the people willingly said, yeah, I'll take medicine right away for a headache. 35% will wait until it goes away on its own. 60% take medications quickly for colds. But for anxiety, only 14% of the public indicates willingness to take medications for anxiety. Only 12% want to take a medication for depression. No one's ever died from a cold that I know of. Depression is much more serious. Why won't they take them? It's because they think, well, I'm not going to be the same if I take a medication. Well, trust me, you're not the same when you're depressed. Or they're going to think it's addictive. That's bunk. They're not addictive. Some of the minor tranquilizers, Valium, Ativan, can be addictive, but the antidepressants aren't. So I think they're extremely safe, considering the benefit from them. The common side effects, yes, about side effects, are really rather benign. They can be annoying, but not dangerous. Dry mouth is very common with the traditional ones like Elavil, Tofranil, Sinequan. Blurred vision sometimes occurs, but it goes away after a couple weeks. Drowsiness can occur. These are not really that serious. In fact, sometimes they can be helpful. I felt the side effects helped me since I was getting the medication in my bloodstream, and I could judge almost how much I had. And the more serious side effects, rarely you see cases where you can have cardiac arrhythmia, cardiac interaction, and seizures, but they're really extremely rare. So the benefits are tremendous, and they're excellent drugs. Other questions? Yes. Okay, her question was, is the treatment for depression going to be pretty much the same no matter where you go? I'd say absolutely not. And again, let me give you an example. For many years in my sewing machine centers, which operate in Cincinnati, I sold exclusively Viking brand sewing machines. That's what I grew up with, selling from age 7 on. So if you came in, let's say you were a quilter, and you came in and wanted a sewing machine, and say, which do you recommend? I'd say, oh, Viking. You came in and says, I'm a tailor, I like to make suits and garments. I'd say, what's the best machine for me? I'd say, Viking. You'd come in and say, oh, I like to do a lot of craft sewing, and I'd say, Viking. That's all I knew. I learned Viking, I grew up on Viking. The same thing I think is going to happen when you go treatment for depression. If you go to a psychologist who's studied under William Glasser, you'll get reality therapy. If you go to one who's a student of the cognitive development, Aaron Beck's considered the father of cognitive therapy, you're going to get cognitive therapy. If you see a psychiatrist who has a medical background with drugs, you're more likely going to find the pharmaceutical approach. All of them can be effective. Again, because of my illustration here, the fellow with treating you cognitively can have great success, if that's all he uses. The fellow treating you with antidepressant medications can have great success. I think my advice to consumers is to shop around. Talk to several different physicians, interview them, feel how comfortable you are with them, find out what's available. I think the key thing is to go to a place where all treatments are available. I was held up for 2 years because my first counselor had an anti-drug bias. He said, you don't need me, they won't help you. Turns out one changed my life within 3 weeks. It took me a long time to find the right one, which it sometimes does. It takes patience. So shop around. The key thing is go to a place where all treatments are available. So I think the best treatment is get the behavior treated, the thoughts, the physiology. Make sure you either go to a psychiatrist who can prescribe medications or to a psychologist who works closely with and collaborates with a psychiatrist to get medications made available to you. Any other questions? Yes, from the front.
Yeah, I have one. Let's say a person decides that he does need to seek treatment and then starts receiving treatment. How long does it take before the problem's resolved?
It varies because they have mixed roots. How long does a runny nose last? For a cold, it's 7 days. For seasonal allergic rhinitis, it's a couple weeks, 6 weeks, maybe in the fall. Chronic allergic rhinitis, it can be all year long or all lifelong. Depressions are the same way. Depends on the roots they have, the basis for them. If it's truly a reactive depression, you can identify a single source of loss, a loss of spouse, loss of job, maybe 3 to 6 months, sometimes with or without treatment. If it's more or less based on lifelong behavioral patterns, low self-esteem, negativity, pessimism, a self-attributional style where they take blame for what doesn't go right, it can take quite a long time to get to treatment. So that's the difference right there, is the roots, the cause. It varies. The only thing you can say for sure, and the thing I have to be careful with, sharing my own personal stories, is realize there's no two depressions are the same. I cannot over-extrapolate my own experience. The only thing you can say for sure about depressions is that they're all different.